is the patient who is having risk of hypoglycemia, a patient of chronic renal failure. So there is a lot of difficulties about the food. Food is, you just can't have every day the same type of food. Even for a type 1 diabetes, I don't know how many of you are writing, but I write for type 1 diabetes a weekdays and weekends prescription separately, because they may have different type of food also, all these things. There are medication which are also responsible for their sugar to go here and there, and that's the reason every time that they have to check, ideally a type 1 diabetic patient, and that is what we recommend, that they should check pre-meal blood glucose level every time. They should count how much carbohydrate they are going to eat, and they should use the insulin carb ratio and correction dose both for taking care of the next meal. And it's a continuous 365 24/7 procedure, and that continue lifelong. There is nothing like that they can change, and this is the what the change is going to happen from self monitoring of blood glucose to the continuous glucose monitoring. It is the activity which is also very important. Rather, there is a separate workshop which we have done with a adjusting the insulin pump, or adjusting the dose of insulin, or adjusting the blood glucose monitoring along with the physical activity. Now you have a type 1 diabetic patient who might be doing marathon running, or you have a type 1 who is doing a intensive physical exercise in the gym, and they all require also the glucose monitoring more frequently, and they require adjustment in their insulin doses as well as in other oral anti-diabetic agents accordingly. There are some biological reasons also, too little sleep, jet lag, and many more things are there. Environmental factors could be there, I mean the expired insulin and something like that, and it is the behavior and decision. These are the multiple reasons for diabetes to manage, I mean not to have very good control in a persons with diabetes. Now 20 years ago, this paper is by Roger Maze. I was there with Roger Maze exactly in 2005 in his center only, and it was a 5 days program. And we were there, and at that point of time, 3 days, he had put all the students who were come from all across the world, put the continuous glucose monitoring. So I remember my first CGM which was installed, and I had seen it was in 2005 only. And he has written one paper that 20 years ago, many physicians treating people with diabetes thought the use of home blood glucose monitoring of any sort was a waste of time and expense. Now, this is, I'm talking in 2005. When he thought of and writing a paper, it was 1985. Why I would use this paper now? Because still we think in 2022 also that in 2005 actually we were thinking that it is of no use to use self-monitoring of blood glucose to use multiple times. The major challenges is reliability of patient data, the glucose monitor which they were using, how reliable it is, whether because many of our patients still continue to test us. They do the glucose meter, the glucose monitor, and they again try in the blood sample also in the lab. Sometimes they put the venous blood also on it, and multiple problems are there. Interpreting patients' data, large number of blood glucose results between the visits also, and time constraints in a busy medical practice. And this is very important, which I had seen. A patient comes with a hundreds of blood glucose report to you. He may show you in last 3 months some 100 reports on a piece of paper, and actually a busy clinician is so much busy that he does not have a time to look into it, and that also demotivates the patient for doing self-monitoring of blood glucose too. The Einstein research developed a series of standardized graphical presentation. Goal was to help physicians quickly recognize a glucose pattern and trends. And actually, the Roger Maze has worked on it, that actually he had collected these hundreds of thousands of the reports, and he tried to make in a graphical form. And since then, glucose monitoring technology has been significantly improved in terms of accuracy and data management. That is what he has done in the form of ambulatory glucose profile. Now, how to help patients to identify their bright spots and landmines, and this is what before meals you have to do, after meals which you have to do, before bed one has to do, and this is what we ask the patient at least 7 times a day. That's not possible sometimes other than in a randomized controlled trial, but what we do is you can do every day 3 times a day, and in a weekends you can do 7 times, or one weekend at least on Saturday, on Sunday you can do 7 times, and in other weekday you can do 7 times, and otherwise 3 times a day, and you can adjust the dose. If hypo and hyperglycemia is suspected, then again you have to monitor at that point of time. So it's not just 6 or 7 times, it becomes 8, 9 or 10 times also. And checking in pair, I mean that is what pairing, monitoring in a pairing, when you are doing before breakfast, after breakfast, before exercise, after exercise. So something when we are doing with a pairing of that is also known as the pairing monitoring, which we do for the self-monitoring of blood glucose. It gives you an accurate check on an average blood glucose level, but it misses the glycemic excursion across the dose. And this is very, very important. And I have a patient, and many of you must have seen the patients after using the continuous glucose monitoring. And this graph which I give you, there is one of our patients, suppose he is monitoring 4 times a day, and that is what recommended. I mean, in DCCT, what they had asked, that you do 3 times a day. You do 4 times if patient is having hypo and hyperglycemia. You do 7 times a day on one particular day, or 8 times a day. And this patient was actually doing, you can see here, 1, 2, 3 or 4. The same patient, when you put on a continuous glucose monitoring, things are completely different. You are thinking that all 4 reports of this patient was absolutely normal. As per the, it is always between 90 to 120 before meals, and post meal also it was fine, 140 or 150. But if you are doing continuous glucose monitoring, you will find that, there are some hyperglycemic peak and there are some hypoglycemia too. Here you can see there is a hypoglycemia, there you can see hyperglycemia, and that is what whatever the number of times person is checking the sugar, in between there is a hypo and hyperglycemia peak. So I always tell, the self-monitoring blood glucose is like a still photo, and a continuous glucose monitoring is like a videography of it. Like self-monitoring will tell at this point of time, if I take a photograph of this, I can show that there are 40% sitting or 20% sitting in this room. That's one time, but after 5 minutes, you all may go away. And it can only show with the continuous glucose monitoring only by videography, whether they all 20 were awake in this meeting, post lunch, whether they were all listening it. This all you can know by continuous glucose monitoring or by continuous videography. You just can't get with a one single still photograph, which we do with the self-monitoring of blood glucose level. CGM's principle, I will not talk much. It is an interstitial fluid glucose level. It is not, new thing in our country. We are using since last almost 15 years, as I told you, continuous glucose monitoring. In our India, it was available and most of us have used it. But current glucose monitoring devices have minimally invasive enzyme-coated electrodes. So continuously evolution had happened. It used to be only for 3 days, then 5 days, 7 days, and now we have even 14 days continuous glucose monitoring device which is available to us. As I told you, CGM capture after meal spikes, and it gives you the trends of glucose, and that is what is required. Why you need the trend? You just don't need only some glucose value to adjust the dose, because we don't want our patient to go in hypo and we don't want our patient to go hyperglycemia. I will talk little on time in range. That concept had come after we started doing the continuous glucose monitoring for our patients. So one is raising the doubt and another is demystifying. The blood glucose monitoring still leaves the question, I am at 160. Am I going to go up or down? We don't know, because at 160, whether patient should be happy or patient should be unhappy, we don't know. Whether after 2 hours of a food, if he thinks 160 is fine, but we don't know how much fat he had consumed. We don't know whether his peak will be coming after 3 hours or not. We don't know how much complex carbohydrate he has taken and what will be the peak of this person. We don't know any idea. And suppose patient has taken more amount of the insulin, probably he may have at 160 at 2 hours may be normal, but maybe at 3 hours or 4 hours he may go in down. That may be at 60 or 55 also. You don't know. You don't know what type of insulin he has taken. If he has taken a regular insulin, which may lead to hypoglycemia after 4 hours, he may have a patient of a gastroparesis where the peak may come after 3 or 4 hours also. And these all things you just cannot pick up by a single report of 160 milligram. If I am going up or down, I am confused. It is the continuous glucose monitoring can tell me that whether I am going down, whether I am going fast, down also, how fast I am going down, that's also very important. So it's a continuous glucose monitoring can provide the answer and more complete picture to allow the patients to make the best decision about their diabetes management. And when we teach the patient, when we try to educate the patient, when we want to empower the patient, that you have to take care of your diabetic management. This is the patient who is taking care of his diabetes for 365 days. He can't meet you multiple times. He cannot afford to meet you. Rather, he can meet you once in 3 months. To diabetologist, endocrinologist, maybe once in a year. He might be meeting his primary care physician maybe once in 2 months or 3 months. He can't afford to meet you multiple times. We have to empower the patient, and for that, these type of devices are required for him to monitor himself and him to adjust his doses also. There are type of continuous glucose monitoring. We have retrospective, that is professional one, and we have real time, and we have personal, that is flash glucose monitoring. I'm sure we have used both type of glucose monitoring system in our country. We have a professional one where the monitor is on by the clinician. So patient has to put the sensor and patient has to come back to the doctor's clinic to get the data, and you get the retrospective data. There are advantages of retrospective data. There are disadvantages of the retrospective data also. It is for 7 to 14 days. You can download all the reports. There is no alarm. Retrospective review of the patient. You have to understand that last 7 days what you have done, last 14 days what you have done. And the personal is owned by the patient. Patient monitor himself. You can come inside, please. The patient can monitor himself. They can see the value by themselves. There are alarms for up and down, and some require some calibration also. So some of the glucose monitoring system require the calibration also, and they can be interfaced with the smart device, and that is what the types of continuous glucose monitoring which are available to us. As I told you, the personal one, the Guardian Connect, which is available to us. We also have the Dexcom, and now new latest which is available to us with Circa CGM. It's a continuous glucose monitoring device by Circa, the Aris. We also have the intermittent scan, which is flash glucose monitoring by Abbott. Again, it is available in two form, which is Libre Pro and Libre. So we have both, again, the professional one, and we have the one which is owned by the patient himself also. The real time is better than intermittently scanned CGM. Now, these all three have their own advantage and own disadvantage. Now, if you talk about the internationally, the Western population, when you can educate the patient, so much so that patient can have the real-time continuous glucose monitoring, and simultaneously he can act also on that. Suppose you are not confident that my patient, if he is going to have the 90 sugar middle of the day, what he is going to do, because you have to tell the patient that if your sugar comes 252, what he has to do, and when your sugar comes 92, what he has to do. So somebody who is on a real-time continuous glucose monitoring, you have to empower the patient so much so. You have to educate the patient so much so that he should know what to do with that sugar report. If you are not confident, then you use the professional one for some days, and you get the report, and you try to teach and educate the patient. See, your last 14 days report shows this and this. Then you have a flash glucose monitoring, when every time you have to do the flashing. In compared to flash, you have a now continuous glucose monitoring, which is better, because you can see in your mobile the way you are seeing that what is the temperature of Goa just now, you can see, or what is the time, the similar way you can see your glucose reading also. But you have to educate the patient for the same, because you should know the patient should also act for the report. He should not come after 14 or 15 days or after 2 months that my all reports were about 250. Even I am using continuous glucose monitoring. What's the point of using that CGM machine if somebody is keeping the sugar more than 250 in last all the day or last 3 days, 7 days, 10 days. So you have to empower, you have to educate the patient. This is one of the paper which is talking that in a 6-month measure, if patient is using real time in compared to intermittently scan. Now, if I am telling something that real time is better than intermittently scan, somebody may say that where the evidence is. Yes, here is the evidence. You can see that a 59.6% time the person will be in time in range in compared to a person who is using intermittently scanned continuous glucose monitoring. The A1C difference between both the group will be 7.4 versus 7.1. But the most important thing is the severe hypoglycemia. And you can see the person who is using real-time continuous glucose monitoring, the risk of hypoglycemia is only 0.47% in compared to the person who is using intermittently scanned is almost 84%, 80.84% for the severe hypoglycemia. This is the continuous glucose monitoring recommendation by American Diabetic Association in 2022. So we started talking about 2005, and now we are talking in 2022 what American Diabetic Association is talking about it. We know that we all follow EDA, we all follow the international guideline, and we also have our Indian guidelines, and where again in this year when we are going to have in 2023 our guideline, we will be also having the statement on a continuous glucose monitoring. It is the 14-day continuous glucose monitoring, assessing for time in range. The glucose management indicator is recommended for glucose management. So it's no more only A1C. I'm not saying that you throw A1C. Self-monitoring blood glucose level, A1C and continuous glucose monitoring, probably I can say they all three are complementary to each other. But 14 days CGM is recommended by American Diabetic Association for a good glucose management. CGM recommended for all adults who take insulin, mainly who are on basal only, even on the basal bolus. They are talking of our type 2 diabetic patients, because those patients who are on insulin, and in India we are many of our patients on sulfonylurea, which can increase the risk of hypoglycemia. As insulin, there is an automated insulin delivery device which is available in India also, with continuous glucose monitoring is recommended for children with diabetes. Those who are type 1, it is recommended that they should use the CGM along with AID, which is automated insulin delivery system. That is what is recommended by American Diabetic Association. And when used in setting of clinical trial or when clinical circumstances such as during a shortage of personal protective equipment required, CGM can be used to manage hospitalized patient also. So somebody who is in hospital, who is not in ICU, who can be also monitored continuously with continuous glucose monitoring. And that's the real advantage, because the patient who is in hospital, otherwise we have to get his sugar multiple times, and that you can save his multiple prick by using a continuous glucose monitoring. Those patients who are not very sick and those patients who are not in ICU, they can be used with this. The ACE also recommend the same. So I mean, American Association of Clinical Endocrinology, in a different language, they are also talking that continuous glucose monitoring is recommended not only for type 1, for type 2 diabetic patients also, and to decrease the risk of hypoglycemia for patients who are on insulin or sulfonylurea. But not only for that, but also for empowering, for educating, for motivating the patients, for even changing the therapy also, a continuous glucose monitoring is really very much required for those patients. The significance of CGM in patients with diabetes: discover previously unknown hypo and hypoglycemic events, useful in trend arrows, that is very important. Value of metrics such as glycemic variability, time span, that is time in range below a targeted glucose level, time above range, and time in range. To know all those things, determine the effect of glucose lowering therapy, to know that how much insulin is going to make the difference. Like we were talking about that one type of insulin, when we compare with other, can we have a two comparison? If we don't do the continuous glucose monitoring, probably we can't do for that. Evaluate the effect of exercise on a glucose control, provide the behavioral intervention based on a real-time glucose value to individualize the management of the patient and analyze the glucose effect of targeted pharmacological intervention, whether fasting and post-meal glucose level both. In a clinical insight, I just give you one or two examples that CGM, when it was compared with blood glucose monitoring, resulted in a significant lowering HbA1c level at 8 months. So we have evidence to show that why we should use the CGM over smbg, and this is the data which I am showing, that there is a significant reduction not only for the HbA1c, but also you can see the risk of hypoglycemia is also getting less. Even the benefit of CGM, many of clinicians, they feel that CGM is to be used only when patient is going for insulin pump or when somebody is going for an advancement in therapy. It's not like that. To understand many more things about the glycemic trend, about the glycemic variability, to know about the hypoglycemia, I think continuous glucose monitoring is altogether separate. It is nothing to do with only with pump. And that's the reason in Diabetes India, this time we had kept a workshop, not combined with insulin pump or advanced insulin delivery devices. It is a dedicated workshop only on continuous glucose monitoring to reduce that how much HbA1c reduction is there, 0.78%, 21 milligram deciliter lowering the average sensor reading, and 11.2% more in time in range with the patients who are on a continuous glucose monitoring along with multiple daily insulin injection. The real-time CGM user improve the time in range compared to smbg user. Evidence of real-time CGM efficacy in type 1 and type 2. We also have the data for type 2 diabetic also patients, and there I had shown you that evidence of real-time continuous glucose monitoring device in a benefiting for type 1 and type 2 both. Real world use of this, there is 308 young people with diabetes, 75% were using CGM while only 25% were using smbg. The real world study also support the use of continuous glucose monitoring in type 1 and type 2 diabetes independent of their treatment design, whatever the treatment which they are taking, still they had used. And to last slide, the take-home message, the self-monitoring of blood glucose measurement do not capture the post-meal blood glucose spike, while continuous glucose monitoring capture post-meal spike and glycemic excursion across the day. CGM provide information about the glucose concentration as well as trend information about the direction and rate of changing glucose concentration. Guideline recommended the use of CGM in diabetes management. Numerous randomized control trials had demonstrated benefits from using real-time continuous glucose monitoring over smbg, including lowering of A1C and reduced hypoglycemia. Thank you. Thank you very much. Thanks, Chairperson. And we will have discussion at the end that will be better, and we will show the device also. Thank you.